have no relevant relationships to disclose on this next section. This section is going to be two vignettes. The first one is I'm going to talk to you about how we organize and how, in my opinion, based on a number of experiences through the years with different responsibilities that I've had and working with different people and organizing sports medicine processes and programs and care and coverage, about how do we, what are best practices, if you will. It's almost like the telehealth thing about you merging, developing best practices. Before today, I thought telehealth was Chicago Med. So, but it's very interesting stuff, particularly for rural America, in Pennsylvania, where I came from originally, and in the Panhandle, and into the areas you talk about there, very much very similar. So that was a fascinating discussion. But how do we organize? And this is, view this as community health. All right, we're helping organize the community health and care and preparation for a group of people. In this case, we're going to talk about. In the second one, we're going to talk about how Andrews Institute, how we've organized over the years the care to a subgroup of population, i.e., secondary school age folks. But these are the principles I'm going to give you in this first vignette, and then the second one is the actual application of this and how it might be organized in the community, and just show you what we're doing in those communities that we serve. So they're like I said, there are best practices, and hopefully at the end of this, you'll learn to understand how experience delivery with an organized team approach is used in sports medicine can maximize athlete health and contribute to performance. I want you to think about this, a word term by Ed Ryan, who's an athletic trainer, has been on 5 gold medal teams with the women's basketball. He ran the U.S. Olympic Sports Medicine program for 10 years. He's our head athletic trainer at the USTA, home of American tennis in Lake Nona. We have 6 athletic trainers there taking care of some 102 courts and all the things, pro circuit players, et cetera there. Ed's there. But he coined this phrase, maximum performance on demand. And the mission in sports medicine is to create an environment for and the expectation of optimal performance and health promotion translating to maximum performance on demand. You'll see this in every slide. People say, whoa, it's all about health. Yeah, you're right, it is about health. If you can't perform maximally, you aren't healthy. And so that's an underlying piece that you have to be healthy to perform maximally. And if you are not healthy, you aren't performing maximally. So in sports medicine, the thought process is, how do I help the athlete perform maximally? But you merge physical, mental, emotional, and spiritual services into the ideal working unit for the maximization of the athlete's and the team's performance. We call that synergy of performance services. All right? That has to happen when you're running a medical school. If you got silos, it's a principle in leadership with anything. You have silos, Don, right? You got this over here, and they're all over the place. And you have silos, and it's my stuff, and you can't mess with it, and I'm not going to help do this. Well, things don't happen in a way that they should. You got the FBI not giving stuff to the CIA, bad things happen, right? Same thing here. All the egos have to go out, and everything has to be merged into a unit where everyone is doing what they need to do. They're being servant leaders, if you will, in every aspect of what they do for the sports medicine delivery, whether it's the Olympic Games or it's high school football. It's the same principles. The guiding principles are that support services must be performance-driven and in unison, maintaining the athlete's health as paramount. The guiding principles are, while it's essential for execution, the athlete's health is constantly assessed, measured using a shared risk gradient, and I'll explain that in a minute. A shared risk gradient concerning the athlete's development status, short and long-term goals, and objectives. It's fluid. It's not just, you have a sprained ankle, take aspirin, come see me in 2 weeks. Okay? That's not sports medicine. Sports medicine is a philosophy. It's not a science. Science are the tools, and we'll talk about that in a minute. But sports medicine is a philosophy. You ask the athlete, what do you consider? What are they training for? Climate, altitude, combination, injured, ill, or healthy at the time you see them. Where on, and I'll explain this in a second, on the injury, illness, performance continuum does the athlete sit? So, The injury, illness, performance continuum, this is where the synergy is really important. So you have an athlete that's competing, whether they be a high school kid, an elite athlete, whatever. They get hurt. They are injured. So they drop from here to here on the scale. Who takes over? Medical primarily. Athletic, depending on severity. So the medical have primary purview over what happens to the athlete at that time. You do an intervention of some sort, even if it's ice, exercise, rest, or it's surgery, or some other thing. You do an intervention, and then they begin, hopefully, a recovery period on this continuum. Well, medical and athletic development pertains to coaching, strength and conditioning. That's a great term that considers everything, so I don't like the word strength and conditioning. It's athletic development. You're developing the athletic parameters for that person. So when they're normal to supernormal, when they're a pro, athletic development is primarily in charge of that. They're working, they're training, they're doing their things. But medical needs to participate in that, i.e. University of Maryland. Sad story, right? That's an example of athletic development without the influence of medical. All right? Those parameters, heat, illness, okay, I'm not passing judgment. I mean, the investigation is pretty much over. Let's just say this. I would like to have seen a scenario where the medical folks could just stop that. All right? And actually, the NC2A has rules around this. The Big Ten Conference has rules, as do the other conferences. The athletic medicine people have 100% purview over play, no play decisions, and they're not allowed to be influenced by administration. So something went wrong there. And that's an example of where this continuum broke down. Athletic development, yes, primary, but not without influence from the medical. All right? To tell them they're going too hard, they're going too fast, wet bulb temperatures are too high, there's lightning coming. All those pieces, these folks get vetoed over this in the ideal world. I'm not saying it happens every time. It should, okay? But what happens is, in this synergy, as the person begins to recover, so that ligament that we just put in, gaining strength, we're following it, right? It's gaining strength. So we can start doing, even in the primary areas of rehab, you should start doing things that lead back to your normal movement patterns in athletics. In other words, it's not just about doing knee extensions, leg extensions. You should incorporate physiologically the movement patterns that are going to be used in your position when you go back. That's why coaches, regular coaches, position coaches should be involved in the beginning as well, because you want to pattern your recovery to those things. So we got hardware, right? Bones, muscles, tendons. We have software, our neural integration. So body, Wolff's Law, everybody's familiar with Wolff's Law, that applies to athletic injuries too. Not just in building muscle strength, not just in the ability to do, stronger, higher, faster, but it has to do with rehab. And the reason you want to pattern movements early so that the neural integration doesn't shut down. The software, they'll throw it out because of Wolff's Law. We don't need that software. We're not going to use it. Then it takes longer to recover that. Does that make sense? You got your hardware, which is your structural pieces, but that integration is your software. And you got to relearn all that. So that's why we start, even after shoulder surgery, at the point where a ligament or whatever is done on a baseball player, we begin shadow throwing, we call it. So they're just not even having anything in their body, in their arm or anything. You just begin a whole series of shadow throwing, so you're reduplicating that neural integration. And then what happens is let's say it was a thrower, medical has primary, more and more you start developing that program, and then athletic development you pass back off to where you try to take them to what I call supernormal. So that's the illness, injury, performance continuum. All right? It's the only thing I made up in my whole life. That you can credit me with that. It's the only acronym that I made up. All right. Now, the underlying duty that professionals miss is the understanding all support for the athlete needs to be performance-driven and not at the expense of the athlete. Support services have to be in unison with the coach and coaching staff, as long as the athlete's health is primary. That's pretty much what I just said. It took 10 minutes to say. All right. But then the decisions also rest and what we call a risk share gradient, and I'll explain this further, determined by the eliteness of the athlete, always considering the competition and performance calendar, the risk of catastrophic illness. Number one, never at the expense Those are no-nos, all right? But when I talk about risk share in second, except for that almost anything's on the table depending on the eliteness of the athlete and a contract between the caregiver and the athlete, i.e. informed consent. I'll explain that in a second. And then with the competition matrix and this illness injury performance continuum, because that determines how hard you can push, how fast you can go, depending on the science of recovery and healing. So on this axis, age of the athlete rising and eliteness rising, and how much are you willing to risk share? All right? I guess mathematically it'd be the area under the curve, right? That's the risk share. What's that mean? That means that an injury is not an injury is an injury. So you have a fracture of your forearm in a 6-year-old. That's a displaced fracture, you have to reduce it, whatever. That kid's not going back to play until that's healed. All right, now you have a professional athlete whose livelihood depends on it. You might risk share with that athlete and say, look, here's the deal. If you play, you may have permanent damage, you may have permanent arthritis, you may have this, this, and this. If it's not permanent neurologic damage, and if it's not death, then that athlete should be allowed to share with you in that. You do that every day with patients anyway, right? Cardiac patient, not at the extreme levels of physical exertion. Cardiac patient, well, I'd like to go on a vacation to blah, blah, blah. Well, you can, but boy, I don't know if they have the medical services. You got to understand that's risky for you there. So, you may not think about it that way, but it is a risk share gradient. You're willing to have that conversation. Anytime anybody talks about a procedure, that's a risk share. You got X percent of getting better, and you got 1% chance of dying. It's an easy decision if you have a pitchfork in your head. You can choose not to take it out, but you better take it out or you're going to have a problem. So that's an easy risk share. So as the athlete gets older, number one, growth plates mature, you can be willing to give up more. And then as they get very elite, personally as a sports medicine physician, if they want to choose permanent and they want to choose degenerative arthritis or traumatic arthritis over winning a gold medal, that's okay. All right? So it's not a cookie cutter, it's not the same thing, one size fits all. Does that make sense? And then the competition matrix, all these decisions are made relative to a competition matrix. What's that mean? It's time relative to a season and time relative to a competition and importance. So you got an NFL player at the end of their career or not that has a torn meniscus in their knee, and this will apply to the next slide a little bit. And the Super Bowl, they heard it in the game before the Super Bowl. You talk to them and say, well, look, we got two decisions. Do we consider the competition and not play to preserve your knee, or do we let you play with this torn meniscus, don't do anything with it, you can play through the pain, and that may give you permanent injury, but you're making that decision based on the competition and importance, and where does it sit in the season? Same injury, so I'll talk about it relative here. Hold on. So, and that's another side. So the same injury in preseason, that season, you may choose to operate on it. And that athlete may come back the last half season playing the Super Bowl, right? But if it's the time frame is different, then you make a different decision. We make that in regular medicine sometimes, I apologize for that term, but more important medicine. We make that decision too. You need a cardiac cath, I need to go on my honeymoon. Well, hopefully you're not that, maybe you're 80 years old. Maybe you need a cath after your honeymoon, but anyway. And, you need to have a cath, you should do this, but I'm okay to let you go now because there's an important event coming. So maybe the time considerations are more compressed than some of the things that, my distinguished colleagues in the audience do. But nonetheless, you're thinking the same way, and it's all sports medicine, okay? Okay. So in the risk share gradient, these are the 4 questions we'll answer later. I like to say that the way I made these questions up, number one, an orthopod made them up so that an orthopod can answer them. So that's, it'll be very easy for you. So, bottom line is, sports medicine is the injury illness performance continuum coupled with the risk share gradient coupled with the competition matrix. All right? That's what sports medicine really is. And I gave an example now that'll suffice for this, but it has to do with the gymnast, the meniscus piece of the wrestler, let's say, beginning of the season, nationals coming up, ACL in a gymnast. That's going to really destroy that gymnast's career. Let's pretend it's a female gymnast. That's going to destroy her career probably if you don't operate on that. That decision probably needs to be taken out of the athlete's hands, because that's just the risk of catastrophic injury in a gymnast with an ACL. They're coming off a jump, they fall off the high bar, whatever. That risk of that neurologic death probably goes up significantly in them, and you can't be able to tell when they land funny. So that's a different discussion with that gymnast than it is with the wrestler, based on the things we talked about. Make sense? All right. So the timing of treatment and training, the bottom line is, the timing of treatment and training is determined by the needs of the athlete, not the support team, based on the most rapid, safe return to competition. We like to say at the Andrews Institute that every phone call to us is a 911 call. It is in their mind, all right, because they're looking with athletes. 90% of who we treat are not athletes. They're regular people like me, you know, that think they're athletes, but they're not. And so a couple last thoughts. The support staff, along with coaches, need to be and understand and accept without measurable outcome of the athlete's performance. They have no role in competitive sport. That's complicated. What's that mean? That's just a measuring stick for you. Remember, maximum performance on demand. You're helping that athlete perform healthy, and that's a measuring stick that everyone needs to be committed to. And you need to recognize and appreciate that competition, performance, urgencies, and emergencies exist. I call that a social emergency. An ingrown toenail on a high school football player on Thursday night with a Friday night game, trust me, that's an emergency to them. All right? So that's what I call social emergency. Now, is that more important than chest pain in a 60-year-old? No. It's not more important from a life and death standpoint, but from the business of sports medicine, the business of medicine, that is important. All right? You're not going to displace somebody getting a cardiac cath emergency to take out a toenail, but we don't have to because we have resources to deal with both. All right? But if you want to exist in the world of sports medicine, you have to think that way to be successful. So, sports medicine decisions, we'll talk about this in a second when we finish at the end. These are some questions to think about. So, in the end, are minor injuries approached with this thought pattern? How will anything change to affect the performance of the athlete? Are non-emergent issues treated as emergent? Does the medical team see themselves as performance-driven, i.e. maximizers of performance within the context of that injury illness performance continuum? And appointments need to be made on the athlete's schedule, not on the caregiver's schedule. All right, you need to have access to people, and this will be important to understand in the next talk here. But it needs to be sensitive to the athlete's needs, immediate care, because of those social emergencies. And your system must be created to do this. If it's left to the individual person to do this without a system to govern it, which is what this slide says, the team tends to have things go awry, and it doesn't work as well as it can. And I can say this to you, too, to within the capacity they can do with general medicine. You know, we try to apply these same principles to, 90% of what we do is not sports medicine. It's total joints, it's ankle replacements. But we try to apply, I'm not saying we're perfect, but we try to apply this sports medicine philosophy to all of our patients. Because a happy patient is one that gets in and there's system limitations for things, and stuff like that. But to the extent that you can think about these principles as they apply to your patients, I think it helps. Okay, I think it helps practices, whether it's just pulmonary medicine, whether it's neurology, whatever it is, to the extent of the limitations within the particular specialty, it never hurts you. So you got to have communication between all the aspects of the people and the synergistic teams and the synergies of performance that exist within these teams. So everybody needs to know that they contribute to the outcome rather than the outcome being primary. The primary focus should be the outcome rather than how much am I contributing. It's not about I and me. It's about we and us. So So any breakdown any time is suboptimal performance, and everyone has to be on the same page, basically creating the environment for an expectation of optimal performance on demand. Enhance competitive without sacrificing health. And in summary, as we said, the IIPC plus RSG plus CM, that is sports medicine. So, do we have questions? Any questions about this? Watch out for the cue. Okay. You've been sitting for a while. You want to stand up for a second? You guys okay? Good? Everybody, you can stand up. Everybody stand up. Yeah. In fact, I'll give you some blood pressure cuffs so we can do some push-ups with those.
I see 3 of them regularly.
Yeah, I know.
Need any volunteers who are trying those bands with anabolics or not?
Yeah, there you go. Well, you know, you mentioned that we talked about, the anabolic stuff. I mean, there's like hundreds of studies on anabolic steroids, and when I was in the anti-doping world, I kept up with that stuff more. But what's interesting is that, there's a genetic component to that some people don't respond like the same way others do. And number one. Number two, you can't just take them. You have to train. And you have to eat correctly, and there's a whole training methodology in how you did things and how you do it for those to have the maximal effect. Plus, everybody metabolizes them differently, which probably has to do with how much they affect you. Maybe if you're a slow metabolizer, they hang around longer. And we're in good shape. That's why we're having a party break here.
No,
yeah,
it's wonderful, David. Thank you.
No, it's good.
This is terrific.
Yeah, so Ben Johnson, Canada. Folks remember him? Some of you guys weren't born then, 1988, right? So it turned out Ben Johnson, so they were, what the doping world used to do when they had the machine in East Germany, in Cuba, they would titrate when they'd stop the anabolics at a time frame prior to the Olympic Games, World Championships, so that they'd still maintain some effect. So you get all this stuff and you get like Arnold, right? But then it goes away once you stop doing those things, right? Over time. But there's a delayed effect, so if you try to titrate when you have to stop with, labs that are not, you have government-run labs, okay? And that's a violation of IOC charter. You cannot go get tested to find out where you are. No lab that's an IOC certified lab is allowed to do that. So UCLA, Indiana, our 2 labs in the country aren't allowed to do that. So the athletes, what they would do is they go titrate coming before games, and they'll learn over the years, all right, I got to stop at 6 weeks, and I'm okay, Well, Ben Johnson was a slow metabolizer, and he missed it, and the timing wasn't good, and he got caught, and that's what happened to him. It's interesting, so the East Germans, all the stuff coming out about that. The Cubans have been doing it for years. In fact, in the Pan Am Games in 1999, which were in Winnipeg, we caught, I was also on the Pan American Games Medical Commission, and so was charging anti-doping and setting up the games, parameters. And though there are 5 weight classes in weightlifting, and 4 out of 5 of the Cubans were caught on nandrolone. And we were threatened by the secret police of Cuba that we better not have another one do that, or we might be sorry, seriously. And so we had to call our Secret Service, and they had some, watching over us a little bit. But yeah, so because those 5, their lab missed it in Cuba. I mean, I'm postulating, but of course that's what happened. The other thing is that, you remember in '92, when, I don't know if you remember Barcelona in '92, the Chinese women won every gold medal except one. I think they had a silver or something in the other one. Remember that? Oh yeah. So, and they never won anything before. So here's the Chinese women, nothing. All of a sudden, right here. Well, guess what happened a couple of years before when the East Germans closed down everything? Where do you think they all moved? Yeah, in the mountain in China. And so then in '96, the IOC, we have a high-resolution mass spectrometer. So that's when they introduced the high-res mass spec, and I'm not saying they did it on purpose, but it's interesting. So the IOC let it out that, yeah, we got this high-res mass spec coming in 96 into Atlanta, and we can detect things a year back, right? I don't know whether they could or they couldn't, but, and how many medals did the Chinese win in one medal? So you go from, you know, statistically speaking, that's pretty statistically significant. You guys have been more expert than I am that. I mean, P there is really, you know, boom, right down. So it's an interesting world. We're chasing our tail in that because they, you know, the more sophisticated we get, the dopers get, you know, more sophisticated. So if you're catching them, generally out of 2,000 tests, you might have eight or nine positives at a game. There's a lot more doing it than that. What?
Hormone in Croatia.
Say that again.
The growth hormones they get.
Oh yeah.
Young athletes in Croatia.
Yep.
They have all these taller.
Yep. Absolutely, and because they're giving them before they're mature, and then you get for the basketball players, and then I can't remember her name, but she was a great German swimmer, but she had frontal bossing him in. She was obviously before he could detect it, she was taking the birth, and obviously was taking the birth hormone. She won multiple gold medals and stuff. So I'll leave you with this vignette. So I had a mentor. I was on the board of trustees at Penn State, and we, before I was athletic director, we would have mentees. I guess that's the right word. I'd be a mentor. So I had a Schreier Honors College student that was a mentee of mine, really bright young man. He went to Jefferson Med School. He was a kinesiology major. This was before Lance Armstrong got nailed. So his thesis, you'll like this, Don. So this kid was really smart. He graduated as #1 Schreier Honors College, and that's a really good honors college program that Penn State has. And he was the #1 student there. So and he loves sports, and so his project was by publicly available data to say or not say whether Lance Armstrong was, you know, hematologically magnifying himself. And he looked at some really interesting databases because the blood tests are public. So in the way the International Cycling Federation, and they're devout of any guild of anything, but anyway, the Cycling Federation and international rule was that the way they did this was in health and safety before they could actually measure for EPO and other aspects of blood doping. We can now do that. They would, if you had a crit above 50, you couldn't race. It was for health and safety, i.e., a higher risk, of coagulopathies and things like that, and could intersect and hurt you. But that's really the bottom line was, yeah, they cared about that, but they were trying to prevent this stuff. Well, he looked at Lance Armstrong's history of that and some other things, and he'd run a normal crit about 45. But then he'd come into competitions and it's 49.99999 and 49.999. And so his conclusion, and that's some other data that he came up with, his thesis he wrote as an honors college was whether Lance Armstrong was blood doping or not. And yes, that was his conclusion. And then about a year later, everything happened. It's interesting.
David, was Armstrong using EPO or was he using his own blood?
I think both. If I remember right. Yeah, I think both, if I remember right.
Yeah.
And you know when you're getting lab tested, right?
Oh, yeah.
So it'd be pretty easy to get a liter of fluids before you go get lab tested and then go, oh, look at me.
And the thing is, and if you test out of comp, so you have in-comp and out of comp. In-comp's everything. That's full menu. So in-comp's everything. Steroid or steroid-like things. Also, epinephrine. Or anything that's or ephedrine or anything like that that's a stimulant. They don't test out of comp for those because that's short-lived. But out of comp, your bang for your buck is the anabolic steroids, really, and or like subjects. And so in the out of comp program, non-announced testing, that's the primary anti-doping stuff that is tested for. And so the athletes don't have to worry about stimulants, but that they're not competing, so it's only going to be a very short-lived thing. But the EPO stuff and everything like that's usually an in-comp thing because it's a short-lived right before you go and everything. There was a Russian athlete in the '92 games. I'll go on to the next talk here in a second. In Albertville, France, and there was a cross-country ski athlete that ended up giving himself a transfusion from somebody else's blood, and he had a severe transfusion reaction and just nearly died and was carried off the slopes. And it was back in the Russian corner somewhere they were doing all this, but just did it. And anyway, an interesting world how they'll progress, and it's quite an interesting cat and mouse game with the anti-doping stuff they get on. Any other questions about that? If you think of some later, happy to talk about it. So, applying the principles we talked about with not the stem cells, but the process with building a community sports medicine program. This is just what we do down in, I'm not saying we don't have all the answers, but it's just a program that's worked for us over the years. In a study published in the Journal of Athletic Training in 2009, I would pay really close attention to this slide, because there might be a question about this, just, but in a study in the Journal of Athletic Training in 2015, only 37% of high schools in the United States had a full-time certified athletic trainer. In fact, the state of West Virginia, to my knowledge, this is probably 30 years ago, was the first state in the union to require high schools to have a certified athletic trainer in their high school. Does everybody know what a certified athletic trainer is? ATC? So an ATC is a person that goes through athletic training. That's an actual major. Athletic training, which is a medical, it's like a nurse practitioner applied to athletic medicine, like physical, it's part physical therapy. They're trained in acute care, like spine boarding, moving people off, AED use, heat illness treatment, as well as rehab. So an athletic trainer is a very multi-specialty, if you will, person. That's a health professional licensed in the state of Florida. Almost every state has licensure now for athletic training. A certified athletic trainer is someone who has, like for the American Academy or the American College of Orthopedic Surgeons, certification, just like you have for pulmonary medicine, internal medicine. So the NATA, National Athletic Trainers Association, is the governing body of academic governing body of athletic training in the United States. And so a certified athletic trainer is someone who's gone through requisite hours of training, et cetera, and degrees, and then takes various tests, and then is certified by the National Athletic Training Association. So that's what the acronym ATC stands for, Athletic Trainer Certified. And you may see acronyms like LAT, which is Licensed Athletic Trainer, and most of the ones that are licensed are certified by the National Athletic Training Association. And so 37% of public high schools in the U.S. have full-time certified athletic trainers. This is in 2015. Actually may have gone up or gone down because there's cost questions with that and how do you pay for them, which relates to our system that we do with Andrews. While 70% of high schools have some athletic training services, they may have a migratory athletic trainer that goes on Mondays to one high school, Tuesday to another, Wednesday, etc. You probably already got the answer to this. I won't tell you though. So, Andrews Institute and Baptist Healthcare, which is the parent organization for Andrews Institute that I talked about, provide full-time certified athletic trainers and physicians to 23 public high schools in a 4-county area. So every high school in a 4-county area surrounding, and all in Florida. But in the Panhandle, basically the 4 sequentially traveling east from the border of Alabama on the west. Baptist Healthcare supports these. We fund these programs 100%. So they're funded 100% for and we view it as a priority to improve community awareness. Many of these high schools are either underinsured or uninsured. So there's a lot of Medicaid here, and so we really feel an obligation to do a service for these young folks that don't have adequate insurance. And some high schools are very well funded, very well insured, but some are not. And so we feel an obligation to the community to do this. And quite frankly, it's also, you do well while you're doing good. So it's called the sports medicine halo. Anybody ever heard of that? It's the idea that sports medicine care, all right, if people think you're good enough to take care of, Dr. J, right? Am I old enough? Then you're good enough to take care of me. That's not as good as outcomes, but professional athletes are very discriminatory, and it's like taking care of racehorses. They're not going to let you be a vet for a racehorse if you hurt the racehorse, all right? So it empirically suggests that the quality's there. It doesn't prove it, but it empirically suggests that. So this halo, but we all have to back it up with outcomes coming into the world now, and we're busy doing that down there there as you are here in your specialties as well. But in any event, and the program was developed under the leadership and vision of Dr. Jim Andrews, who we talked about earlier. So, what does our program include? It includes an extensive community education program, which is really key. So to impart things not just to the booster clubs, but also to the coaches, to the athletes, and we have a robust program which is growing to impart things like discussions on concussion management, on general health and wellness training for athletes, proper training, also heat illness, also weather problems, weather issues, etc. So we offer an extensive program both to athletic directors, coaches, and to people in the community at these schools as number one, a benchmark for the program. We also have 24-hour access on call to athletic trainers via a phone for daily medical coverage as well as injury evaluation and management for all the partner schools. That's that piece we talked about before about, you know, the 911 call. Everything's a 911 call with these kids, and most of the time it's not a 911 call in your world, but it is in their world. That's all right, 911. Whose phone's that? We set that up well, didn't we? Good job, thank you. Perfect. Good job. So this is a program and this program was established long before I got there. I've been there, you know, coming on 3.5 years now. But this program was well established before I ever got there. I just managed not to screw it up. And so we start a season off, number one, with as much education as we can, and we do that throughout the competitive year. But Florida has a rule that and all state associations have similar rules that the athlete has to have a complete pre-participation physical exam, history and physical exam prior to competing, at least one a year, and if they have an injury or a problem, they have to be re-evaluated after that injury or problem to be recertified again. I mean, not if you had a broken toe or something, but if you had some significant illness, you have to be recertified again. And so what we start with is a program that we do 15 to 1,800 student athletes on our campus on one day in June, because that's where the time frame usually lies, on the first or second day. And we do this pre-participation physical exam for 15 to 1,800, and we do that from 7 a.m. and we're finished by 3 p.m. And it has to do with multiple people helping in multiple phases and stages of doing different exams. And that ultrasound exam would really help. We do this, but we do use a cardiac echo if indicated. So what we do is we do, you know, height, weight, vision, orthopedic musculoskeletal exam, physical exam, and a cardiac assessment.
I have a question.
Yes, sir.
I'm jumping the gun.
No, it's good.
Cardiac assessment.
Yes, sir.
If you have a high schooler who has an echo or who has a heart murmur,
Yep.
cardiac assessment.
What we do is, and there's certain guidelines that have changed, okay, for a long time, we have about 10 years history of doing every sophomore in this, doing an echo. Now, it turns out that's probably not, you know, for free. I mean, our echoes, you know, our radiologists would read it and et cetera, and so the guidelines have changed, and what we do now is, so we'll have our general docs, we don't hang a stethoscope on an orthopod, okay? So anyway, we stick to our own. I used to wear them around so people thought I was smart. You know, I didn't know you. You know what the orthopedic point is? Right here.
Oh yeah.
Yeah, that's everything. You hear it all.
I told him that yesterday.
Yeah, no. Vowel sounds, breath sounds, heart. You know, that's better than that ultrasound stuff. So anyhow, but you have to be sure not to have the ear things in. Just let it hang here, and then. So anyhow. So what we do, so we have different stations. They'll come in one of our building at our research foundation building. They come in and get the height, weight, and they go through musculoskeletal exam with our and they rotate through a whole process on our whole campus, and they come through. And they end up in the clinical building in our ASC, and all the rooms utilized except for the operating rooms, but all the pre-processing rooms. And they'll have various stages of exams by people whose expertise is that. And then we'll have our general, you know, our primary care docs. And we'll get a lot of cooperation with Elgin Air Force Base. They'll send down 5 or 6 docs to help us out in doing these physicals in the community, and all of Baptist physicians help even that aren't part of Andrews. And if there's any tripwire on history, family history, something weird, or on exam, then we partner with Nemours, pediatric cardiology team that are in Pensacola as well, and they'll be there with their chief of program, Mary Maya, and their fellows. And so they will then they'll listen to see if if the auscultation shows that maybe they should have an echo. We have echo right there, and we can do it. So we'll go that auscultation, exam, regular cardiogram, echo. We can do those right there with the athletes as they're there, and they go. So out of 1,500 last year, I think, and these are approximate numbers, we had about 40 that tripped the wire to maybe they needed have a cardiologist actually examine them. Of those 40, I think we did like 12 echoes. They were cleared before then. Some may have a cardiogram or something. And then out of those 12, there were 5 or 6 that had restriction to play until they had a further examination. And then luckily all of them were cleared, but they weren't allowed to play until they went and got a further examination. Of course, you can't predict electrophysiology problems, so that's one of the issues that we can't predict yet. But maybe by family history, things like that. And I'm starting to get in areas that I'm really not an expert, so I ought to shut up. But I know at least peripherally about that. So it's a good question. And then if they're not cleared, they go back. But literally, it's an impressive. I didn't do it. I just watch it. It's an impressive phenomenon how to process these athletes. And we probably have 100 caregivers, that are doing it amongst our athletic trainers as well as our physicians and nurses and people that are there helping do that. Yes, sir.
Do you send any? I'll preface this with why I'm asking. So I used to do this in a city I lived in that was an underserved city.
Right.
A lot of them were single parents. Parent worked multiple jobs. They wanted to play sports, but mom or dad wasn't going to take them to the doctor.
Right.
So I used to bring
It
in.
costs them $40 or something when they go to the doctor.
Right.
Yeah.
So I bring in my med school's family medicine interest group
Sure.
when I was in residency and after. We run everybody through. I had one kid once, so I'm listening to his history, I'm listening to his heart. I finally said, I just don't think I'm going to be able to clear you with what we have here today. Mom looks at me and says, yeah, we knew that might happen. Cardiologist told us he'd never be allowed to play. So, do you send anything back?
Well, that's a signal.
Yeah.
Yeah.
Oh, yeah. Do you send anything back to these kids' primaries to say, hey, they had this done and they got cleared? Not that we read everything that comes back. I hate to say that, but just so that if we have somebody who go, wait a minute, this kid should never be cleared.
I know. We see it sometimes, and we worry about it. Some in our concussion management program because I'll talk a little bit more about that in a minute. Because for instance, those are 2 areas probably where the world's progressing. The cardiac management as well as the concussion management and CTE and traumatic TBI and whatever. And there are really much more specific guidelines for return to play now than when I was training. And it used to be when I was playing football, if you weren't slobbering, you could go back, and a lot of us did. God knows I have no problems from that. But nonetheless, but now it's very specific, with talk about baseline testing and all those things that we do, and with return to play, and how you weave them back into this classroom and use of their brain and everything like that. But a lot of docs, not that they're, don't, and that's just not their world. They don't keep up with it, so they're using maybe in the community some of the old, techniques of clearing for play, and then we worry about that a little bit. Not to throw stones at anybody, trust me, but because it's become much more specific about return to play and what's okay and what's not. So you're right, very similar. But of course, it creates this issue sometimes. So you have the team doc, and one of the things that really makes our system work really well. We have the advantage of having 9 or 10 fellows and plus 30 docs, and almost all of them help. Even the hand surgeons participate, and our spine surgeon and do better at a game. The spine surgeon that are trauma docs, and so each doc and an athletic trainer match at a high school. So you have this continuity of care, that synergy we talked about. So our program is fairly unique because a lot of hospital systems will sponsor 50 high schools with athletic trainers, but it's different docs and different people there. They're not in the same system. Now, people obviously, you can't say you have to come to see us. We don't do that. Obviously, I say you can go to anybody you want. No, I want to go see you, because 99% will choose to follow up, obviously, with the institution that they're comfortable with. But it doesn't guarantee it. So then you get into a problem where, you get a doc in the community says it's okay to return, and our folks don't think so. So that can create some, it does it collegiately too. I mean, there are situations where the athlete says, my doc says I can play, and we don't let you, but the institution has the right to not allow you to play. So that's where it kind of falls back on. Yes,
Isn't
sir.
that what happened to Bo Jackson, when 9 orthopedists tell him don't play any more, sports, and he, with his hip replacement, and one says, oh yeah, go ahead.
I know, it happens, I know. And they'll search, and athletes will gets back to doping, okay? So we had a gymnast, he was very good, I won't even tell you where, because if it didn't exist back then, but it's a really good gymnast, it was going to be world class. And she had basically she had a navicular fracture, scaphoid fracture of her wrist, which can be very problematic, as you may or may not know. They have a high propensity of avascular necrosis, you get chronic pain, degenerative disease, or whatever. And they really need to be treated. And she was coming up on a trial, and we were sitting there talking to her, and said, and her mother was there, because every time you see a gymnast, the mother's there. I mean, it's like figure skaters, and they're all there in the team meetings and everything. Okay, we said, no, you really have to have a cast on for 6 weeks. If you don't, you're really going to run the risk of this thing not healing. And she ultimately, and I'll come back to that story, she ultimately sought enough opinions that somebody let her do it, and then her career, it didn't heal. She went back, she didn't heal. But we asked the mother with the athlete sitting there, and this is a 16-year-old athlete, we said, if we could give you a drug that would guarantee you winning a gold medal in 2 years, but would also guarantee you'd be dead in 5 years, would you want the drug? Both the athlete, doesn't surprise me that much, but the mother said yes. Seriously, I mean, that's the issue you're dealing with in some of this. Not everybody's like that. Not everybody's like that, yeah. So we guarantee a gold medal and guarantee death in 5 years. I mean, I was in the room when I heard that. So, that's off track a little bit, but it goes back to this question about physician shopping and things
Well,
like
in a
that.
day and age when you can walk into a little clinic or an urgent care and get them to fill out your sports physical, saying, hey, I'm not allowed to go back to sports till I get a physical, could you do this?
Do you feel okay? Yep. Yeah, you're okay. Like a driver's physical, go get your driver's test, right? Yeah. So, you're right. Yes, ma'am.
What kind of sports do you handle? Like golf?
Yep.
Swimming?
Yep. Yep, all of them. So we take care of, I'll talk about it in a second here on another slide, but we take care of all sports. I mean, the combat sports, all right, collision is basketball, combat is football, rugby, lacrosse. I mean, those are boxing, wrestling, judo, and those are combat sports, so there's a high risk of injury. So the combat collision sports always have an athletic trainer on site, and then all other sports at the games and practice. The other sports, and luckily in high school you don't have 2 combat sports going on at the same time. In college you have more athletic trainers, so you can cover those. And then the other sports have the availability of an athletic trainer on campus during those things. There's a staged delivery. So golf would not have an athletic trainer, but we ask that all of our coaches be, certified, CPR certified and whatnot, to assist in the regard, and all train in first aid for even golf or sports that don't necessarily have to have an athletic trainer on site. But yeah, we take care of all the sports for all those high schools.
Is soccer a combat sport?
Yes.
So,
Concussion rates in soccer are higher than football.
You don't intentionally use your head in football, so that
No.
makes sense.
Well, sometimes you do. But yes, soccer is a very high concussion rate sport, and it's interesting, and particularly in females. And females have a much bigger brain, and so the heads weighs. I'm kidding, but it's true, right? I'm just trying to, the females have a bigger brain. Actually, they do, but females have a larger brain, so they're carrying more weight on a smaller neck, and so that's why females have higher neck pain problems, and also probably relates to concussion problems, maybe.
Make sure you don't forget cheerleading. We often get more cheerleading.
Highest risk. Yes, sir.
Anything else?
That's the highest injury sport there is. Absolutely correct, sir.
Cheerleading?
Yes.
Well,
Because of the aerobatics and things like that they're doing and stuff, and yeah, very severe injuries occur in cheerleading.
it's hard.
Tough. So that's a combination of gymnastics and throwing people, basically. I mean, and so that's
Like judo with the willing
partner.
Exactly. Just letting you do whatever they do to you. I know. So anyway, that's our preseason exam, and okay, we're in good shape. So I won't tell you the answer to that. I bet you know it already. We'll go at the end. I'll give you the answers. And then we have a continuum for concussion care. All right, we have an extensive program. We actually test more athletes because they're out there. And in the fall, when we do them in June, we don't just do football. We do all sports that want to come. They don't all come, but we'll do 2,200 baseline tests. We use the Cleveland Clinic C3 Logics. The two major systems are Impact System out of the University of Pittsburgh, and then C3 Logics, which is the Cleveland Clinic, concussion program, and that's our baseline. They're pretty similar. And we do concussion evaluations during games, and then we also have return to play post-concussion management, very regulated system, and we also do vestibular management for those that are problematic in our PT programs to help bring these athletes back. And there is, like I said earlier, there is facilitated access to the Institute for Physician and Women's Diagnostic Imaging Surgery and Rehab. The key to this is you don't want to displace other people that need care. You want to take care of these folks in addition to those folks. So you don't want to displace somebody so that's the art form about developing your program and how you can do this so that you're not delaying care for other people in lieu of the athletes. You're doing both. And so that's really a true art form to do this and help those people that need it the most. We also offer free Saturday morning student-athlete injury clinics, which is a really our docs and our athletic trainers will alternate weekends, and they'll each have one on a Saturday morning. We run from about 9 in the morning till noon. Free walk-in for a lot of games are done Thursday, Fridays, be that football or any sport. Yes, sir.
Who funds all this?
We do. Baptist Healthcare does.
Okay.
Mm-hmm. Yeah. It's a lot of money.
Yeah.
Yeah. Close to $2 million a year. Yeah. But we're really big believers in this. In this one, and we've expanded it to more and more. We're now really getting into the club, and so there's a lot of club sports. I'm sure around here, with like volleyball clubs, the USA Volleyball sponsored clubs. There's in Pennsylvania, there's wrestling clubs and things like this. But there's baseball clubs, softball, all these things around the community. So we've just inked a deal with USA Volleyball to be their provider, and then there's some 43 volleyball clubs, in a wide radius of Pensacola. And what we offer is an athletic trainer that's always on. We've hired a full-time FTE athletic trainer to take care of those clubs in the sense of fielding the phone calls from clubs. We also then we cover selected tournaments, where higher injury rates may occur. We do that for the Roger Scott Tennis Center in town as well. We have an athletic trainer on call, but we're not there every day for the recreational athletes, but we'll facilitate their care. We have a clinic that's close there, but then when they have tournaments, we'll offer coverage there as well. But we do an extensive number of triathletes, community sports programs that occur, sailing. Sailing's big in Pensacola, and so we'll cover those sailing events. We'll do all those things with our community outreach athletic trainers as well. And that's in addition to the athletic trainers we do in these programs. Very important. So you got a pre-plan, right? You don't walk in the cardiac suite and I wonder how we're going to do this calf today. Maybe we'll use this or we'll use that, or this is what happens when you have when you have code blue, you know exactly, or whatever you call it in Valsalva, code Valsalva, or whatever. But you have an arrest. You have a sequence of events that's well dictated. Everybody understands what happens. Well, we develop emergency action plans with each high school ahead of the season and have it adopted by the high school. And it's things like you think about. This is what you do during lightning. This is what you do, and there's a warning here. And it's all. Not saying we thought everything, but there's certain standardized EAPs that exist in the NATA world and things like that. And we take those and implement those with the high schools, and we get sign-on with the high schools that we take care of, so that everybody's on the same page of how this works and what we do. So that's really integral and important to doing this. And again, it helps provide guidelines, team physician as well as administrators and coaches on how things are going to happen and how they should, both preseason and at games. We emphasize growing relationships with area EMSs, so we involve them in those EAPs as well. And this is important. So spine boarding has been the rule of thumb for many, many years when you have a potential spinal injury. But there are two of our counties, I think, at least one. Their EMS doesn't do that anymore. They don't spine board. they do a slide board that goes under and they pick you up and cite you, if you will, and take you, which isn't a bad way to do it necessarily. I mean, there are, in the Olympics, we use bee bags, you suck the air out of them, and it freezes the athlete in that position. Then you roll them over so there's no movement. You know, when you traditionally move someone with a potential spinal injury, even as good as you do, you have 6 or 8 people doing it, head stabilization. There have been studies that show that there's still a lot of wiggle going on in those things. And so some of our counties do spine boarding still, some don't. So we've had to develop individual EAPs with those that incorporate that into the management of these problems. And we work with all the people that are part of this and the planners to develop these situation plans and awareness and education. Heat illness management, can't emphasize it more, particularly here and in Florida. You don't take them to the hospital first. You drop them in cold water immersion immediately. Period. All right? The kid in Maryland, that's what should have been done. All right? So Doug Casa, he's an athletic trainer, PhD out of Connecticut. He's the world's expert probably on heat illness and prevention and saving lives. This is the number one thing you need to do in the pre-planning in high school. Every one of our high schools have a tub that's about the size of this table. And each game is filled with ice water. And it's interesting, you look at the physiology, you think, oh my God, you don't want them to shiver, right? But you don't shiver. You know, going from 107 to 102, they don't shiver. You know, and the faster you can drop their core temperature, the better it is for them. Now, drop you in there, you'll shiver. But it's funny how, you know, you have 107, 106 degrees core temperature, you don't shiver going down. And so the key is to have that there available so that you can drop these folks in immediately. Then you put them in the ambulance after they're in the cold water emergency. And that's nothing in the world's dogma, right? But that's pretty much dogmatic. I mean, if you're really going to do it, but a lot of places don't realize that and still working on it. Yes, sir?
I guess it's old news, but I was taught way back that you didn't put them in cold water because it's basic constriction and it wasn't as fast as lukewarm or cooler.
Colder the better. Yep. That's right. It's one of the things that, you know, and fans don't do anything, and, you know, putting cold bags on their heads and stuff, don't do it. I mean, and you don't want to put them in the ambulance before you do that. I mean, if you suspect heat stroke, you know, that's the point, you know, when your core temperature's out of 106 or whatever it is, you know. So.
Is the armed forces doing this now too?
I don't know, but I can't imagine they're not. But I don't know.
Okay.
I don't know.
That's the correct answer. I mean, you just only have chemicals too, if you can't find anything else.
Yeah, you just go. You know, and if you have an EAP, then that's part of your EAP. You know, the EAP is you're gonna have a tub there. Now, what happens is you find out, do you guys have a tub? Yep. Where is it? Well, it's in, and this has to do with AEDs too. You know, do you have an AED? Yeah. Where is it? Well, it's back at the school. Well, you got 3 or 4 minutes, right? All right, you got 3 or 4 minutes to slap a defibrillator on somebody, maybe 5 at the worst. I don't want you to do me if I'm 5, okay? Yeah. But maybe we'll see. But nonetheless, you know, so they have a tub. Doesn't have any water in it. How long does it take to fill this tub up? You know, and it's too late. You know, so it's got to be, and that's where these plans have to come together to have this set up ahead of time. And maybe it is somewhere filled up, but who has the key? Seriously. Well, the athletic director. Where's the athletic director? Well, he's up in the top of the, you know, press box, and we got to run up and get the key from the athletic director. So you got to have it right there on the field to use it properly. That's an NFL requirement, and that's NC2A. I mean, they won't operate in any other way than that. High school world's hodgepodge at this point, but all of our high schools, that's how it's done. Lightning and weather precautions, we just instituted weather tech. The counties buy them, so you detect lightning 10 miles away. You know the deal about you count, and for every 5 seconds it's a mile, and because sound travels at 1,000 feet per second, give or take at sea level.
So if we happen to be at a game and there's not an immersion tub, can you do things like take ice packs to the axle?
Won't do much good. If I was going to do it, now I'm not the expert, I guess I'd take a hose and just start spraying the guy down. I mean, you know, if I had it. Yeah. Yeah. Sooner you got to take their clothes off basically, and you got to get water all over them and get the core down. But that's a tough situation if they don't have it there. mean, at that point, if I didn't have a tub, I'm thinking out loud, if I didn't have a tub, I didn't have access to cold water, you know, I probably would get him in the ambulance, but I would try to start throwing water all over him as fast as I could, you know, and then get him to somewhere. But the hospital's not gonna have that. They don't have a tub at the hospital, so they got they're not gonna have it. So it's really critical to have.
Old ID. Yeah.
That's true, take a long time, you know, a little longer though. Yeah, so when you have a neurologic injury, you're doing core down to that. The fastest way to get it down is in these cold emergent tubs.
Yeah, the question is, you know, we just tell them to teach emergency medicine. That's outstanding.
I'm not that smart. I just read it yesterday. No, I'm kidding. No, thank you. So I'm not, you know, so maybe I am as smart as an ox. You know, the orthopedic thing is twice as strong as an ox and half as smart. So maybe I'm as smart as an ox, not necessarily you guys, but something like that. I don't know. Well, it just comes with 1,000 years of watching this stuff, I guess, you know, but thank you.
The other thing you said that I was curious, it's more important to make a decision than it is to be right.
You bet. You know what, one of my favorite sayings is that was General George Patton, and he said, a good decision made made immediately is far superior than a perfect decision made tomorrow. All right? So, that's true. So if you think it's the right thing to do, it probably is. You know what I mean? Yeah. What's the old axiom in medicine? Yeah. So game day coverage. So now we evolve pre-game, come to game day coverage, and now here we are. We've got the team physician, certified athletic trainer on sidelines. Again, I said earlier, collision sports, which I would say combat sports and collision, take priority for game coverage, but the athletic trainer is on campus for all events. Then one thing we do before every combat game, i.e. football, is we have a medical timeout. And that's where the EMS, the coaches, the athletic trainer, and the physician sit there and say, the catastrophic injury you're thinking about. All right, when this happens, this is what we're going to do. This is who does what. We have a spine-ish situation. You're holding the head, most experienced person with the head, and down the line, even integrating the coaches into that. Because really, to make a good spine transfer, you need a minimum of 6 people, okay? Ideally 8. So you've got to incorporate with the EMS and everybody there how you're going to do those things and have that decision made before the game starts. You talk about the heat problem. You talk about if it's a bad weather situation. And this is how we're going to do it, and you just do it one more time. It's like checking an airplane before you take off, right? This is how it works right here, the checklist. And you go through that before each game. AED availability. So not only at games, every one of our athletic trainers has a portable AED, and they're all trained to use it. And they have it with them at all times. We've actually saved 2 lives of spectators in the last 2 years by doing that, running up in the stands and saving spectators with the AEDs that we have. So our foundation, Baptist Foundation, just bought 12 of them. So that some high schools have their own, but that's the deal. We're locked up back in the school, and what are you going to do? And so we wanted all of our athletic trainers to have an AED with them at all times, and they do. They carry it with them. So everywhere they are, they have an AED, and it's helped. It's worked in helping people in the community over the years. So in any event, here's the very hard questions. In the risk share gradient, one thing we don't do, permanent neurologic damage and death. So, as a physician, I won't allow you to choose that. All right? Even if you sue me, all right? You can choose arthritis if you're elite enough. All right? You can choose long-term whatever if you're elite enough. Non-emergent situations should be approached as routine, little bearing on competition, never considers effect on performance of the athlete. That's none of the above, obviously. We've done that. And the Journal of Athletic Training, I gave this away at the first slide. I mean, I told you guys to read the slide. And 37% of high schools have certified athletic trainer. That was 3 years ago. It might be more or less. Like I said, some may be cutting programs across the country. And a community sports program should include all these things, in my opinion. Pre-participation, concussion management, facilitate access to care, and